Good evening, dear doctors. Today we are going to conduct another great clinical episode on our XP Connect webinar education series powered by Wallison Technology from GE Healthcare in association with Society of Fetal Medicine. Today we have another pioneer in the field of diagnostic ultrasound and fetal medicine, someone who needs no introduction. Please welcome Dr. BS Ramamurthy. Dr. Ramamurthy is a consultant radiologist at Srinivasa Ultrasound Scanning Center, Bangalore. His field of interest is fetal medicine, and he is the chief patron at the Medical Ultrasound Society of Karnataka and coordinator of Fetal Foundation of India. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If you experience temporary interruption in the transmission, kindly bear with us. We will sort it out immediately and resume. Kindly do not log out and keep refreshing the screen every 30 seconds. I now welcome Sir to address our viewers. Over to you, sir.
Thank you, Madam Zeenath. Thank you, Team GE, and welcome participants for this evening's webinar. We will be dealing with the fetal CNS in the 11 to 13 weeks, 6 days period. Now, we all know that the 11 to 13 weeks, 6 days scan has come to stay. It's a part of standard obstetric care, and therefore this window provides us an excellent opportunity not only to look at the viability of the fetus, not only to look at the number, the Leica volume, the markers of aneuploidy, markers of preeclampsia, so on, but it gives us a wonderful opportunity to look at fetal anatomy as early as 11 to 13 weeks and 6 days. So, as far as the CNS goes, we need to understand that there is a certain basic minimum that we need to do in our everyday scans in this period. So the first of this requirement is to look at the cranium in the axial sections or the transverse sections. And just like we have our transverse sections in the mid-trimester ultrasound, we also have the transventricular, the thalamopedunculae and transcerebellar views in the first trimester. So the only difference here is in the second trimester or the mid-trimester anomaly scan, we call it transthalamic view, but here I would prefer calling it the thalamopeduncular view because you see the cerebellar peduncles as well. So what do we see in these three views? We get to see the presence of the midline, extremely important, symmetric calvarium, choroid plexus, the lateral ventricles, the posterior fossa, and remember the lateral ventricular cutoff, the size cutoff in the first trimester is different. At around 10 weeks, the transverse diameter of the transverse ventricle would be about 3 millimeters, and around 13 weeks, it goes up to 5 millimeters. So remember, the 10 millimeter rule does not apply to this window of visualization. Now, here are a few standard pictures. This is a classical transventricular scan, transventricular section, and in this, immediately you recognize the presence of the midline Fox echoes that you see, and you have two choroid echogenic plexus, echogenic choroid plexus on either side, and this midline and the two choroid plexuses mimic the butterfly, and this was Sepulveda's 2004 article, which called it the butterfly sign. Now, in addition to that, we must realize, yes, we are able to see the lateral wall of the lateral ventricle, that brilliant echogenic line there, a specular reflection that you see on one side and on the other side, and you will realize that the choroid plexus is contacting the lateral wall. That means it's like a tight plug. It doesn't look loose at all. Between this line and another echogenic line, which represents the pile surface of the cerebral hemisphere, that is the mantle. That is the cerebral parenchyma that you see at this stage. And quickly we realize that the cerebral parenchyma does not occupy much space at this stage. It is the ventricles and the choroid plexuses that are predominantly taking the volume of the intracranium. We also should realize that you see the calvarial plates out there. You see the sutures which are quite wide, and we will revisit this towards the end of the presentation again. So those are the sutures, but what really takes the center place here is the butterfly sign and the presence of the midline. Now, as early as this, we must recognize that transabdominal is what we do in day-to-day practice, but whenever there is a difficulty in visualization, a difficult patient, an obese patient, or presence of some anomaly or some anatomical region which you're not able to sort out with transabdominal, you have a wonderful window, that's the transvaginal window, which takes you so many notches above and makes your life a lot easier, right? So we need to liberally use transvaginal ultrasound wherever possible, and if there is an element of doubt or difficulty of scan in any situation. Now, this is a transventricular clip that I'm showing you, and first of all, we realize that yes, it's a tight wall-to-wall fill of the choroid plexus. Remember, the anterior horns are relatively prominent at this stage. You will see the two anterior horns happening there, but the choroid plexus does not reach out in the transventricular plane. They do not reach into the anterior horns. They are empty. They are full of CSF, right? Sometimes you will realize that the choroid plexuses may be asymmetrical. One may be a little longer or shorter than the other. No big deal, nothing to be worried about. So a little bit of asymmetry at this stage is perfectly allowable or admissible. Now we move on to the thalamo-peduncular section, which is a section which passes through the thalami, as you see here, and the cerebral peduncles, as you see here. The thalami are much broader. The cerebral peduncles are much narrower. You can see them very well over here. And of course, you see a bit of the frontal horns with the choroid plexuses, which are extending almost up to that point onto this side of the image. So this is the classical thalamo-peduncular. And when you take recourse to the transvaginal scan, you will see that the anatomy is much better displayed. You see the two thalami, and when you see the two thalami, the midline structure between the two thalami is definitely the third ventricle. So that's the third ventricle, and these are the two cerebral peduncles. Remember, the cerebral peduncles are a part of the midbrain, and the cavity of the midbrain is the aqueduct of Sylvius. Just like the anterior horns or just like the lateral ventricles, which are very prominent at this stage, the aqueduct of Sylvius also is very prominent. You can see it both in the transvaginal scan as well as this little complex over here in the transabdominal scan. Also note the fact that the cerebral peduncles do not reach all the way up to the occipital bone. Look at the gap between the peduncles and the occipital bone, and that's important when we come into the area of the neural tube defects, and we'll take this point up again for consideration. Now, since the thalami are broader than the peduncles, if you draw a line along the lateral aspects of these structures, they would converge, and they converge normally at the occipital bone. So that is the detailing that you get in the thalamo-peduncular section. Moving on to the transverse cerebellar section, you typically get into the posterior cranial fossa, and when you get into the posterior cranial fossa, you find all these structures that you look at in terms of the intracranial translucency on a mid-sagittal section. You can recognize all of that in the transverse plane passing through the cerebellum or the posterior fossa. So you have the brainstem there. That's the posterior surface of the brainstem, the intracranial translucency. Then that's the choroid plexus. That's the cisterna magna. So just like you see these structures on the mid-sagittal, which we will do in a short while, you also see them in the transaxial or the transcerebellar axial plane. At a plane which is a little caudal to this plane, you find that the cerebellum gives way in the midline and the fourth ventricle communicates with the cisterna magna, and that's the classical open fourth ventricle, which is not pathological at this stage. It's simply because the vermis has not finished its development, and if you leave it enough time, the vermis comes in there and it segregates the fourth ventricle from the cisterna magna. So remember, an open fourth ventricle is perfectly normal at this stage of gestation. Now, the other structure or the other section that we need to look at is, we've finished the three axial sections. The only other section that we need to do at this stage is the mid-sagittal section. Anyway, you're going to do a mid-sagittal section for looking at the nasal bone, the nuchal translucency, the maxilla, so on and so forth. So, in the same section, you have to shift your focus from outside of the cranium to inside of the cranium, and that's why it's called intracranial, and look for this translucency. That's the intracranial translucency. So the same structures that we enumerated a little while before. So that is the brainstem. Posterior surface of the brainstem is the first echogenic line, then a hypoechoic band, which is the fourth ventricle or the intracranial translucency, and then another echogenic band, which is the choroid plexus and the cisterna magna, and out there is the occipital bone, and outside of that is the nuchal translucency. We will come back to this again when we go into the area of neural tube defects and screening for neural tube defects, right? So with the advent of Doppler, you could see the vasculature in the fetus, but remember, seeing the vasculature in the first trimester is extremely difficult, but thanks to slow flow HD algorithm, filtration of the Doppler signal, you begin to see slow flow as well. You will see that this is slow flow showing you anterior cerebral artery out here. This is the slow flow of the circle of Willis as early as 12 weeks. And you will note that the circle of Willis looks a little larger for this kind of skull size, but that is normal. So we do not know what use do we have of this at the moment, but now technology puts this power into our hands. It tells us, it makes us aware of what's happening in terms of vasculature in the first trimester beautifully. Now, what are the lesions? Having done normalcy, what are the lesions that we're going to encounter by doing these sections routinely in day-to-day practice? So we will go through Acrania Iniencephaly, Cephaloceles, open spina bifida, Holoprosencephaly, lateral ventriculomegaly in sequence. Now, at this stage, CNS anomalies are the most common. 40% of them, 40% of all the anomalies are CNS anomalies in this particular window of study. Now, straight away, we go on to a very simple condition to diagnose, that's acrania and iniencephaly. And this, of course, is a 12-weeker, and the clip shows you the spine, shows you the aboral end or the caudal end, and the cranial end. There's something very dysmorphic which is happening there. You don't see the calvarium. The brain is misshapen, it's exposed to the amniotic fluid, looks a little disorganized. And when I go into the transverse section, you see the two orbits there. Orbits are well preserved, but there is no calvarium out there. The brain is up and out, contacting the amniotic fluid. That again is the spine, which looks fairly normal, but there's no calvarium. And this is the Mickey Mouse sign. And this is the classical frog-eyed appearance or frog appearance. You see those relatively prominent orbits which are seen so markedly well. So that's classically acrania. I would call it acrania because there's a lot of brain which is still left there. But over time, this brain slowly gets resorbed or gets dissolved, so to say, into the amniotic fluid, and that is why a little later, as you go on, if you do a serial study, you will find that the brain actually disappears in future scans. The LICA volume becomes particulate because it's proteinaceous debris which is getting loaded into the amniotic fluid, and eventually the brain tissue actually disappears, giving rise to the classical Iniencephaly appearance where there's no calvarium and there is no brain as well, right? So that is the classical acrania Iniencephaly example to begin with. The next lesion that we can diagnose with great confidence and also a lethal lesion is Iniencephaly. Now what happens in Iniencephaly is some very marked departures from normalcy. First of all, at this stage or at any stage, you find universal flexion is the way a fetus is comfortable. Even now, when you actually go to bed, you tend to bed, and some of us even get into our fetal positions. We find it comfortable to get into a state of universal flexion. But here is a fetus which is extended. It is so much extended that the occiput is almost coming and contacting about the first half of the spine there. So there is a persistent hyperextension at the craniovertebral region. The spine is extremely short. You find a continuation of the intracranium into the spinal canal. Look at the fact that there is no posterior ossific centers over here, right? And when I go and trace the anterior aspect, I find that the skin from the chin is continuous with the skin in front of the chest, right? Meaning that there's no neck, right? So a short spine, presence of a spina bifida over there, an occipital encephalocele going through the foramen of magnum, communicating with the spine out there, and most importantly, this very abnormal craniovertebral hyperextension are all features of Iniencephaly, and therefore we've diagnosed a lethal anomaly. So once you have a volume, you can play and do what you want with it. This is VCI, volume contrast imaging. This is render HD live with Salute showing you the hyperextension, and this is the render mode maximum showing you a very faint spine there, but nevertheless unmistakable hyperextension there, and a boggy nuchal edema out there, right? So we move on to cephaloceles next, and a cephalocele is a congenital calvarial defect. There is meningeal or brain protrusion. Meninges always there. Whenever you call it a cephalocele, it means meninges have herniated out, plus or minus brain. It's sporadic most of the times, but sometimes it is syndromal and sometimes it is disruptive, and it can be associated or it can cause the Chiari II malformation. If only the meninges herniate, you call it a cranial meningocele. It's just a pouch of meninges which has come out through a bony defect in the occiput, and there is CSF in it. It's a cranial meningocele. If there's a brain tissue within the meningocele, you call it an encephalocele, and if a part of the left ventricle also has entered into the herniated content, you call it an encephalocystocele. Now here is an example of the fetal cranium and a thin walled structure which is at the occipital aspect of this particular cranium, right? There is no brain tissue seen there. That is the 3D showing you the cranial meningocele. So a classical example of a cranial meningocele. On the other hand, all these three pictures are examples of cranial occipital encephaloceles, because in all of them you are seeing brain tissue which has herniated out in addition to the presence of a little CSF as well. And that is the bony occipital defect that you see here. The bony occipital defect. That could be a little small defect. It could be a huge defect. This is a very small cephalocele, but you still see the defect over there, occipital bony defect over there. And what more, you also can see a sausage-shaped cerebellum, right, telling you that there is an Arnold Chiari type II malformation. So these are examples of occipital encephalocele. When they are big like this, no big deal. You will brilliantly see this and pick them up. But some small occipital meningoceles can be a problem. Now look at this clip that I have for you. You can see that at one particular point, there's a small little nubbin of tissue. Not only the meninges, there's a bit of the brain also going in there. That's the lesion, and that's a encephalocele in the occipital aspect. You can see that very, very well over here. So very small encephaloceles can be a challenge, but with careful scanning that we always do, we are able to pick up such lesions, right? Now here is a frontal encephalocele. I will stop this clip. I'll get this going. This is the occipital aspect. You see the thalamus and the peduncles happening over here. That is the posterior aspect there. And from the frontal aspect, you have a huge protrusion or herniation of brain tissue out there. And that is a frontal encephalocele. A frontal encephalocele, whether it is frontal or occipital, if the content herniated outside the volume is good enough, then that will cause the cranium to become smaller inside. That's not a direct microcephaly due to lack of growth. It's a consequent microcephaly. Because of the herniation, the cranial volume comes down, and secondary to that, your measurements can come down, and that is what can be noticed, especially in reasonably sized encephaloceles. So that's a frontal encephalocele. We'll stop this clip. And in the same features, of course, this is a transvaginal study. In the same clip, you have an ectrodactyly. That's one of the upper limbs, forearms there, and you see the ectrodactyly happening there. And once you have volumes, you can do your surface rendering, and you can do your rotation model showing you that large frontal encephalocele at around 12 weeks in this particular fetus, right? So this is frontal encephalocele plus ectrodactyly. Another transvaginal study, and in this what you can see is that the calvarium is here. That's the calvarium, but at a point which is not in the midline, you find a small little protrusion happening, a subtle but small little protrusion. In fact, there are two of them, one here and another one there, a very, very small protrusion. And associated with that protrusion, you find a small little band there. Can you see that band? That's the band there. And this is a rendered image. I've taken slice thickness of about a couple of millimeters thick. You find that this is the small herniation. That is the band. A small herniation, unmistakable herniation. That's the band. And this is a part of whenever an encephalocele is neither occipital nor frontal, when it's off the midline, please think of disruptive processes. And one of the commonest disruptive processes that can occur in the fetus is the amniotic band disruption sequence. So in an amniotic band sequence, you find that the amniotic band attaches to the area where the disruption has occurred, and that is the result of the disruption. So off midline encephaloceles, please look for amniotic bands, think of amniotic band sequence, and these are details that you get only when you do a transvaginal examination. But we had our clues on transabdominal. It's not that we directly did a transvaginal, but because of these clues that you get on 2D, and those clues were actually the presence of bands, the presence of extension. This is the forearm of the same fetus. That is the hand of the fetus. And this fetal hand was always held in extension, which is definitely abnormal. And when you do a transvaginal ultrasound, looking for why this is happening, you find that the arm is tethered by amniotic bands. The hand is tethered by amniotic bands, right? The foot is tethered by amniotic bands. You do a rendering, you find the face there. That's the hyperextension of the wrist on one side, hyperextension of the wrist on the other side, and you find the bands happening over here. So these are all a part of amniotic band disruption sequence. Now, once you know there are bands, you will go after these findings. You will carefully look for encephaloceles. You will carefully look for amputation of digits. You will look for subtle signs of gastroschisis. You will list out all the features of disruption. You look at the face carefully because the orbits, the nose, the lip, all can get disrupted. You will be put on the right track, and all you have to do is to follow the protocol, knowing that it's a disruption and finding out all your lesions, right? So that was an example of a disruption. Now, the other common syndrome that we meet up with, of which occipital encephalocele is a part of, is Meckel-Gruber syndrome. This is an autosomal recessive syndrome, and once you see large cystic kidneys in the first trimester, your antennae go up. That's a large cystic kidney out there. You will begin to look for all the other stigmata or features of Meckel-Gruber syndrome, and you will first of all go to the hands. You will see that there is a polydactyly, both 3D out here, 2D there. That's the extra finger which is happening here, extra finger which is happening there. So that's polydactyly. You at the umbilical cord insertion into the abdomen, you find a small omphalocele which has occurred, though not a particularly a particular feature in Meckel-Gruber syndrome. In this particular fetus, we did discover a little omphalocele out there as well. So you have polydactyly, you have large cystic kidneys. Now you have to look for the encephalocele, and that is the clip that you have there. You will see that there is a big herniation out over here. That's the brain coming out. That's the occipital defect. So you have everything together out there. You also try to look at the lip, because cleft lip, cleft palate are also a part of this spectrum. So classical Meckel-Gruber syndrome, and in fact Meckel-Gruber syndrome is much more easier diagnosed in the first trimester than second trimester, because in the first trimester the LICA volume still doesn't disappear. The kidneys are not the source of LICA. In the second trimester, the kidneys are the source of LICA, and therefore you have an anhydramnios in these cases. Makes imaging very hard. In the first trimester, you have the luxury of amniotic fluid, and you can pick up those findings much easier. Now, this is a study by Sepulveda's group, and they found that the occipital lesions were the commonest, of course, and followed by a contribution by the frontal, parietal, and non-classified lesions. And encephaloceles are commoner than meningoceles, and of course 11% of times they found Meckel-Gruber syndrome, amniotic bands in about 6% of times, right? And most of them opted for a termination. 5 of them landed up as abortions, intrauterine death, or neonatal death. Post-op, doing well is only 1 out of 27. So in the first trimester, an encephalocele pick generally means a poor prognosis. The only case where you can paint a good picture is if it's only a meningocele. There is no herniation of brain at all. The rest of the fetus is normal. You've done your chromosomal microarray showing everything normal. Then those fetuses can have a good prognosis. Now, from here we will cut across and go into the spine and spine of the feet. We'll get back to the head. We'll cut across, go to the spine, and spine should be imaged in the sagittal, transverse, and coronal sections, right? Ossification is done and over by about 10 weeks. There is no splaying of the posterior ossific centers that you see on the coronal section, and that's called the railroad appearance. You find the dorsal skin continuity. Just like what you do in the mid-trimester, you have to replicate the whole process in the first trimester with documentation. And that's the sacral taper that you have to demonstrate. Remember, to look for skin continuity along the spine, you need LICA volume. You need amniotic fluid. If there is no amniotic fluid and the fetus is sitting on the myometrium, you cannot deal with you cannot be very sure about the continuity of skin over the spine. Now, lesions like this are detectable in the first trimester. You have ventriculomegaly there. You have adenoid Chiari malformation or Chiari II malformation there, and you have a lesion in the lumbosacral spine, a huge big lesion playing and all the signs possible. But a lot of times it becomes more challenging. Here is another case. You have again picked up transverse section. That's the sagittal section, and the same fetus, a big lesion which you can see there, easy to pick up. Those are huge lesions along the spine. You will be able to pick them up. But remember, the spine is best studied with like a volume, not without like a volume, as is illustrated in this case. Here I've shown you dorso-posterior. The spine is actually in contact with the myometrium, and therefore we are not able to see the skin continuity. It stops there. There is lica there, there's lica here, I can see skin, beyond which I don't know what's happening. So I can even see a little bit of like a taper. Now, if I were to report this spine as normal, I would have missed something. And what actually brought this to my notice was the cranium. When I look at the cranium, there's a classical frontoparietal flattening, the lemon sign. And when you get into the occipital region, transcerebellar, you find the classical sausage-shaped cerebellum, the banana sign. Now that is enough clue for you to get back to your spine and very, very assiduously wait. Let the baby turn, let the fetus turn, do a transvaginal ultrasound, and you pick up this small little lesion at the tip of the sacrum. Thanks to these signs, we were able to make this lesion out. 3D, 4D really doesn't help over here. That's the lesion, and that's the same fetus after abortion termination, showing you the subtlety, the smallness of the lesion. These are lesions which are difficult to pick up, right? Then that is why we need alternate screening strategies to make the pickup of open spina bifida better in the first trimester, right? The fact that we saw the intracranial signs in the first trimester was more an exception than a rule, because most often the intracranial signs come in the second trimester, not in the first trimester. And therefore, Ravichavi et al. Put forth the intracranial translucency as a screening parameter for open spina bifida in the first trimester. And of course, if the intracranial translucency is normal, you will most often find your spine normal on a routine assessment. If the intracranial translucency is abnormal, then you need to do a targeted spine assessment, not only on transabdominal. If you're able to show the lesion on transabdominal, good enough. But if you're not able to show it, you must get into the transvaginal mode and look at the spine again through the transvaginal route. And then, of course, you have to rescan at around 15 to 16 weeks if your transvaginal scan also is inconclusive. You have to go after the spine in a very, very targeted manner. So we will see what is IT, why is IT abnormal in OSB, and what is abnormal in abnormal IT. So we discussed this a little while ago, saying that there are 1 and 2 echogenic lines if you leave the occipital bone. There are 2 echogenic lines separating 3 hypoechoic bands, and the middle one is the intracranial translucency. The first one is the brainstem. This is the midbrain. That is the thalamus. That is the midbrain. That's the thalamus. So the thalamus, the midbrain, the brainstem. That is the IT, or the fourth ventricle. This is the cisterna magna. Classical picture that you see here, and I've annotated the 3 white lines, or the 2 white lines, and the occiput, and I have annotated the cisterna magna out there, and that's the intracranial translucency, or the fourth ventricle. Now, what is this asterisk? This asterisk has to be the brainstem, as we saw in the previous slide. And Chavi et al. In 2010 just asked us not only to see outside of the cranium, move your gaze upwards into the intracranium, and you have a load of information happening in the posterior cranial fossa. So the intracranial translucency increases with gestational age. It's about 1.2 millimeters at 45, CRL of 45 millimeters, 2.5 at 85 millimeters. Now, once you see a thing, you begin to measure it. In my practice, I don't measure the intracranial translucency. I just eyeball and document the intracranial translucency. But if there's any doubt regarding the normalcy of the anatomical structuring which is happening there, you will begin to measure. So here in this particular normal scan, you find that that is the brainstem diameter. This is the posterior aspect of the brainstem. That's the brainstem to the occipital distance that you see here. So always remember that the brainstem AP diameter is much lesser than the distance between the posterior aspect of the brainstem and the occipital bone. And since the brainstem is always smaller than the BSOB distance, you will find that if you do a BS brainstem to BSOB distance, it's always lesser than 1. You eyeball it, that's enough. If there are doubts, only you get into the mode of measurement, right? So that is the brainstem diameter, the brainstem occipital bone distance, and the ratio. So you have 3 things to understand, and that can help us in cases where you feel there's an abnormality. Now, what happens in open spina bifida is that there's a Chiari II malformation, and in Chiari II malformation, there is a caudal displacement of the brainstem. Now, because the brainstem moves downwards caudally, it distorts the anatomy of the posterior cranial fossa, and therefore those structured 2 lines and 3 hypoechoic bands do not show their normalcy, becomes abnormal, right? So now what are the abnormal findings? We know normal. I have put a normal here for your reference. This is definitely doesn't look normal. All of you agree with this. I hope you find the 3-band, the hypoechoic 3 bands here. You don't find the hypoechoic 3 bands. Here you have normal, the brainstem is narrow. What's happened here to the brainstem? Brainstem is broad, right? Here you have the intracranial translucency, which is seen beautifully. Here the choroid plexus, cisterna magna, intracranial translucency complex is obliterated. So you find that the brainstem is broad, the brainstem is kinked. Can you see the kink which is happening? Yes, it's broad, and the BSOB distance, which must be greater than the brainstem, now is much closer. So BSOB distance is greater than the BS diameter. So all the information of abnormal findings that you can pick up are seen in this particular slide, right? So because you have seen, you will go after the spine, and needless to say, you find an open spina bifida there, you find a disorganized spine there, and when I play the clip out for you, you will certainly agree that there's a huge lesion out there. Now, even without observation of intracranial translucency, you would have picked this up. You would have picked this up, but remember, what we do is to go at the cranium first, get your mid-sagittals, and then you look at the spine. So even before you come down to the spine, here you have a prompter in the posterior cranial fossa which says, look, there is something abnormal, the brainstem is broad and there's obliteration of IT, so go down and look at the spine carefully. And that warning especially is very, very essential for us to pick up anomalies. So the same thing happens in a smaller lesion down the spine, right? So that's the kinked brainstem in another case. You see there you are. That's the kinked brainstem happening in another case. Here is, of course, the same case which I've shown you the measurements and telling you that the brainstem BSOB distance is greater than 1, right? So you have tables for BSOB distance, the BS diameter, and the BSOB ratio as well, and you have the sensitivities, specificities for each of them worked out, right? So here is another case showing you a broad brainstem, BSOB distance is less, and the ratio is 1.08, right? So therefore, it's not less than 1, it's more than 1, telling you that the brainstem is broad, again abnormal. I don't need this, my eyeballing is enough. I've just done it to demonstrate how measurements can help sometimes. And in the same case, you begin to see the spine, there is a spina bifida, there's a spina bifida, and also intracranial signs. You have the thalami, the peduncles, right? So the thalamo-peduncular view, you had to have the cerebral peduncles much narrower than the thalamus, but here it is not. It's almost the same. So this is called the parallel pedicle sign or parallel peduncular sign, and a very great sign to tell us that there is something happening down the spine. Also note the fact that the peduncles are very close to the occipital bone. Remember, normally there should be a certain distance which separates the occipital bone from the peduncles, and this is called the crash sign. Literally, the cerebral peduncles have moved on and crashed into the posterior aspect of the occipital, the inner aspect of the occipital bone, and you find the classical banana sign which is happening over here. So one sign leads to another, leads to another, leads to another, and you put everything together, you have diagnosed an open spina bifida. Again, another example, altered posterior cranial fossa findings on mid-sagittal section, and of course a huge spina bifida over there. That's a diaphragmatic hernia that you see in the same case. Now let's look at this case. Here is a transabdominal ultrasound, and from a mile away we know that this is abnormal. There is the normal structure is gone. You don't have the two white lines and the three bands happening there. The brainstem is broad. But when I look at the spine in all manners, I've done a transvaginal ultrasound, I've taken volumes, I've looked at the spine very well, directly as well as 3D, I don't find anything, and that's pretty distressing. Here you have a sign, but the spine, you swear and you know that it's normal. And that is where you've got to look for a very small encephalocele. And when I go up into the cranium on transvaginal scan, you find a little small, this is hardly 3 to 4 millimeters that you see here, a bump there and a herniation inside, and that's the 3D of the small little occipital encephalocele. Remember, an occipital encephalocele also can cause a Chiari II malformation, and if it causes a Chiari II malformation, it causes an abnormality in the intracranial translucency. So abnormal intracranial translucency, normal spine, please be sensitized to the possibility of a small encephalocele and look for it. And that is the clip showing you the smallness or the little small lesion that you have picked up on a transvaginal ultrasound, right? This is the sensitivity, specificity. We will skip that. And also remember that in closed spina bifidas, you hear the skin is continuous. In closed spina bifidas, you will not get an altered intracranial translucency. The intracranial translucency is normal, right? Now let's go to the other end of the spectrum, which is a very prominent intracranial translucency. Now here is the thalamus. That's the brainstem. This is the brain, midbrain. This is the brainstem. The brainstem looks narrow, agreed, but the intracranial translucency is large. I have measured it over here. You put it onto the tables, you will find that it's more than 95th centile. And when you do a transverse section or an axial transcerebellar section, you find a cyst which is happening in the posterior fossa. So this is how a cyst presents on a mid-sagittal section as an increased intracranial translucency. Now let's look at one such case here, and then we will revisit increased intracranial translucency towards the end of this presentation. I'll just take you through one case here. Now here is a 33-year-old, third gravida, third degree consanguinity. She has one child who is 11 years with Joubert syndrome. So she comes with a flag. Now when she comes with a flag of Joubert syndrome, you're worried about posterior fossa. And when you do your nuchal translucency cut, you find that this is a cyst which you're not used to seeing. The brainstem is normal, it's not broad, but this distance is increased and there is a cyst which is happening there. So the IT is unusually large. And when I do the axial sections, the transventricular plane is normal, but in the posterior fossa, you find this cyst, which again is abnormal. I am not used to seeing a cyst like this in the posterior cranial fossa. So therefore, you have to put 2 and 2 together. Joubert syndrome, first trimester abnormality in the posterior fossa. Are you going to press the panic button, say that this is a recurrence? We all know that Joubert syndrome is a ciliopathy. It's autosomal recessive, 25% chances of coming back. There is history of consanguinity. So the good chance that this could be a recurrence. But I didn't have the guts. I didn't have the guts to say that this is a recurrence. I bought time. So this is a very important message. If you have any kind of doubt in the first trimester, you are not forced to give a diagnosis at this stage. You still can wait. Give time for embryology, give time for dysmorphology to evolve, and you can always purchase time, you can get time, repeat the scan, and you will realize that in 99% of times, you will be able to clinch your diagnosis after a time interval. And that's exactly what happened here. She went away, I told her, I didn't give her hopes, I told her there is a problem, I told the couple, but I'm not going to press any panic buttons, you come back to me closer to 20 weeks, right? And that she did, she came at around 19 plus weeks. 19 plus weeks, you see the posterior fossa, certainly abnormal. The fourth ventricle is dilated. The vermis is present, but it is not that nice, thick, chunky vermis. It's a thin vermis which is now separating the cisterna magna from the dilated fourth ventricle. The AP diameter of the fourth ventricle is longer than the transverse diameter, which is very unusual. Remember, the fourth ventricle is always wider than AP longer. Here it is the reverse. Here it is the reverse. And when I go down, there is a subtle open fourth ventricle which is occurring. This is a direct mid-sagittal section. Remember, in the posterior fossa, there is no final diagnosis in the mid-trimester without a mid-sagittal section. In the mid-sagittal section, you find that the fourth ventricle is dilated, the vermis is lifted off, and it's become kind of thin and linear. You still see the echogenicity, but a highly dysmorphic vermis out there. So with this, I was much, much more confident, and I said this is a recurrence. So this is a recurrence of a Joubert syndrome in the first trimester, presenting as an increased intracranial translucency, and in the second trimester you have found a classical vermian hypoplasia, a vermis which is elevated from the brainstem, and a fourth ventricle which is, as a consequence, which is dilated. So therefore, buy time and be sure of what we are going to diagnose, right? This is Volpe et al. 2016, and remember, increased thickness of the intracranial translucency can evolve into a Blake pouch cyst, evolve into a Dandy Walker, can evolve into a Vermian hyperplasia, can evolve into a Joubert syndrome morphology, so on and so forth. So therefore, in a case of increased IT or a PCF cyst, so how do we go about the situation of an increased intracranial translucency or a PCF cyst, a posterior cranial fossa cyst? So first of all, we've got to look for associated anomalies in the current scan that we are doing. Secondly, we must plan a karyotype or even a chromosomal microarray. And thirdly, if there's any doubt regarding the diagnosis, which oftentimes there would be, we need to wait till the mid-trimester anomaly scan, or you can even prepone. You can even prepone the classical 18 weeks or 19 week scan. You can prepone it to around 16 weeks and take a look at what's happening, right? So from there, the IT obliterated versus IT dilated, we will go on to another dimension of an anomaly which can occur, and this again is an early event. We know that at around day 40 conceptual age, the telencephaly, the telencephalon actually develops from the prosencephalon. So the prosencephalon gives rise to the telencephalon and the diencephalon. So therefore, this is a very crucial event, and if it fails, and very, very rarely it does so, you will not get the telencephalon which is formed. There will be only the diencephalon. When the telencephalon doesn't form, the cerebral hemispheres don't form. But since the diencephalon is present, you will have the midbrain. You will have the basal ganglia, that is the thalami. So the thalami are present, and the cerebral hemispheres are absent. So let's look at a very rare situation, but nothing is rare. Tomorrow, one of y'all might kind of meet up in your own practices. Here is the fetus in question. A transabdominal ultrasound shows you the mid-sagittal section more or less. But what is striking here is I wasn't happy with the contour of the forehead over here. It looked a little flattened. And it was a difficult case, so we said we will go transvaginal. And on transvaginal scan, this is what I saw as far as the fetal cranium goes. It's an axial section. You see the two cerebral peduncles, and they are the cerebral peduncles because they sandwich the aqueduct of Sylvius, very clearly seen. And the cerebral peduncles are contiguous with the thalami. So you see the two thalami here. This is the index case that we are studying now. And to compare, I would put a similar section in a normal case. So that's the aqueduct of Sylvius, the cerebral peduncles of the midbrain. And then that is the thalamus on either side, thalamic bodies. And then in the same section, you see the anterior aspect of the cerebral hemispheres. Now, what is missing is this. There is no choroid plexus, there is no anterior horns at all over here. So that raises the question of absent cerebral hemispheres with presence of thalami. And therefore, we need to think of this very rare disorder called Iniencephaly. And to make things more clear, I'm just showing you a 3D Cynical, which shows you a stack of images as they move from end to end. Very, very clearly, you see the thalami very prominently. You see the midbrain and the posterior fossa, but you have no sign of the cerebrum, no sign of the midline forks, no sign of the butterfly sign. So therefore, that is a clear-cut case of Iniencephaly. Now we move on to a much more commonly seen lesion, at least not as rare as Iniencephaly, and that's Holoprosencephaly. The Holoprosencephaly is suspected when you see up front there is no butterfly sign. You're used to seeing that midline and with the two wings of the choroid plexuses on either side, and that is missing. Instead, you see a monoventricle, the thalami are uncleaved, and you might, if you study the metopic suture, chance upon the premature closure of the metopic suture. Now here, what is the embryology? The embryology is that from that holoprosencephaly, that one prosencephalon, you get a telencephalon and a diencephalon. That is what we discussed a little while ago. But that one telencephalon ultimately cleaves into two halves, into two lateral halves, the right and the left, giving rise to the right and the left hemispheres of the cerebral hemispheres. When this happens, when the telencephalon doesn't cleave, the prosencephalon doesn't cleave, that means neither does the telencephalon cleave, nor does the diencephalon cleave. So the uncleaved status gives rise to holoprosencephaly, and as the name actually implies, it is one whole prosencephalon, hasn't cleaved into its two resultant halves. So those are the signs that help you diagnose or suspect holoprosencephaly, and we'll go through about 2 or 3 cases to drive home the point. Now this is a transvaginal scan. You see the thalami. The thalami should have a midline echo, which is actually the third ventricle, which tells us that the thalami are actually cleaved, and there are 2 thalami. Here the thalami are running into each other, telling us that it's a thalamus that is not cleaved. There is only one thalamus there. More importantly, I see no butterfly sign, no midline at all across, no choroid plexuses at all on either side of the midline. But instead, I see one primitive monoventricle moving from side to side, stretching from side to side, actually draping over the uncleaved thalamus. When I move into the face region, you see a finger-like projection jutting out of the area where the nose should be, and that is the proboscis. That's the proboscis there. There is jugular sac dilatation in this fetus. You can see the two jugular sacs, and this is the neck region. Needless to say, this is a transabdominal version of the same fetus. Shows you a very thick and boggy nuchal edema out there, and there's a tiny little small omphalocele which is happening there. So that is a small omphalocele. That's the cord insertion. And whenever there are multiple things happening, we need to again look beyond just alobar holoprosencephaly. We need to look at it as a possible syndrome, and the commonest syndrome which occurs with holoprosencephaly is Patau's syndrome or trisomy 13. Right? So here's another case. We will move back to another case, and this is, of course, same heart-shaped, uncleaved thalamus, a huge ventricle which is draping over this thalamus out here. This is a sagittal section of the face showing you a proboscis. Instead of the finger-like projection, proboscis sticking out as we saw in the previous. This one is pointing upwards and is actually flush against the forehead like this. So there's no nose, there is a proboscis which is seen, and if you see very, very carefully, there are two tiny orbits over here which are extremely close to each other, very close to each other. And when I look into the abdomen, you see the kidneys are quite prominent, they are hyperechoic. So whenever there is an intracranial finding in terms of an alobar holoprosencephaly and extracranial, extrafacial, facial anomalies are a part of the alobar holoprosencephaly complex. It's called a polytopic field defect. They are embryologically related. But if there are remote findings, like for example in this case, large echogenic kidneys, that's definitely a remote finding. And if you have extracranial, extrafacial problems, then please think again of trisomy 13. And of course, a karyotype in this reveals a trisomy 13. That's the fish showing you the three dots over here, which tell you that 1, 2, 3 green dots, 1, 2, 3 green dots, telling you that there is the chromosomes 13 which are present in the amniocytes. And of course, this is the regular karyotype showing you the 13 chromosomes out here. All the others are represented only by pairs, whereas this is a trio. So this becomes a trisomy 13. Now, in trisomy 13, we also have an accessory sign, which is accelerated ossification of the frontal bones. And because of accelerated frontal bone ossification, the suture in between the frontal bones becomes narrow and ultimately it closes prematurely. And that can be seen by doing a coronal section passing through the face, not through the lips and the chin though, but a little posterior, going through the frontal region and going through the nasal cavity and the oral cavity, orbital cavity. So those are the frontal bones. These are the cavities of the orbits. You can even see a little bit of the intracranial structure, intra-orbital structures there. That is the oral cavity, and there's a part of the nasal cavity. These two are the prematurely ossified frontal bones. And the metopic suture, which should be much, much wider, it's a V-shaped, much wider structure that you see normally, but here you see it as a thin hypoechoic line, telling you that this is premature ossification of the frontal bones and premature fusion of the metopic suture. And of course, needless to say, what prompted me to do this was the fact that there is a holoprosencephaly. You can see the monoventricle, the choroid plexus are continuous along from one side to the other. There is no falx cerebri that you can see here, and there is a large midline cleft which is moving right into the hard palate region, the secondary palate region. And again here you have hyperechoic kidneys on either side. So always look for this additional sign, and that will only get your diagnosis more complete, and you have recognized yet another feature, right? And this is, of course, Kegan's article showing the association of megacystis, exomphalos, and trisomy, and holoprosencephaly with trisomy 18, trisomy 13, and trisomy 21, respectively, right? Now, lastly, before I finish with this presentation, is the question of ventriculomegaly, and this is oftentimes a very sore point. How do we cannot apply the 10 millimeter rule for obvious reasons, because we're doing the first trimester the scan before 13 weeks, 6 days. So therefore, is there a cutoff? Unfortunately, we don't have a cutoff at this stage. Around 5 millimeters is what it is, but we don't really look at it as a cutoff. But what we look for is actually the way the choroid plexus is seen vis-a-vis the fluid around it. Normally, the choroid plexuses are large, the amount of fluid is less. That is normal. Whereas if there's a ventriculomegaly, if there's a buildup of CSF within the ventricles as early as this stage, what happens is the fluid component becomes more. There is no, if you measure this is almost the same as normal, no big deal. But the look is important. The amount of fluid, the CSF becomes more, and at whose expense? The choroid plexus. The choroid plexus becomes more kind of limited, more kind of, bunched up. It doesn't look like that nice wing of a butterfly that we are used to. So therefore, people have actually compared the length of the choroid plexus to the length of the ventricle, or the area of the choroid plexus to the area of the ventricle, and produced ratio thereof. And you have charts for these ratios as well. But really, your eyeballing is enough to tell you that. And let me take you through what are the implications of lateral ventriculomegaly. Extremely important. It's isolated in about 30% of cases. It's got associated anomalies in about 70% of cases. And if you karyotype this subgroup of fetuses, you will end up getting about 31% of aneuploidy pickup. You need to look very carefully in the scan that you're doing now for associated anomalies. So look for associated meningocele, an occipital meningocele or an encephalocele. Look for the facial profile. Then look at the limbs to see if the limbs are short, unusually short. Look for midline clefts in the palate region, the lip region. Look for polydactyly. Look for chamber asymmetry. Look for cardiac disease, an AVSD, and look for an omphalocele. These things can be seen if you pursue, and if you really switch your probe and go into transvaginal, become much easier, right? And if you don't find anything, it's called isolated. It's an isolated lateral ventriculomegaly, and you will have to really wait a little longer. As I said, if not 18 weeks, at least till 16 weeks, and then you see how it is going to progress. If you wait all the way till 20 weeks, you might even pick up a Dandy Walker malformation. You might pick up a complete agenesis of corpus callosum. And if you wait till 26 weeks, you may be even in a position to pick up malformations of cardiac, you might be able to pick up a malformation of cortical development, or a megacystoma magna, or a Iniencephaly, as I said. So amongst the chromosomal anomalies, of course, we have trisomy 13, 18, and 21, which may be associated with early ventriculomegaly as well. So let's look at this case. In this case, lateral ventricles are dilated. The choroid plexus looks limited, and there's a postcranial fossa cyst, a huge cyst, in fact, pushing the cerebellar hemispheres right against the walls of the postcranial fossa. So that is a straight case of a lateral ventriculomegaly. But remember, the measurement doesn't help you. The look helps you. More of fluid, a small contained choroid plexus, right? Whereas in this particular case, this is abdominal version. One look, you know that this is not the normal configuration of the choroid plexuses. They look small. They look rather bunched up. And who's taken their area? The fluid. The fluid has become a little more, and it's definitely it's eye-catching. There's no doubt about it. And of course, when you move into the posterior fossa, there's a midline posterior fossa cyst here, which has actually pushed these two cerebellar hemispheres apart, right? So therefore, you have a posterior fossa midline cyst there, and you have ventriculomegaly, signs of ventriculomegaly. So it's, and that of course is the mid-sagittal section, shows you the posterior fossa cyst over there, and we'll come to the other findings a little later. So immediately what you need to do is to change your probe. Enough is enough. You need to see this brain a little better. And when you put on your transducer, the transvaginal transducer, and you start doing your examination, things become extremely clear. Look at the quantum difference. You have the findings here, but look at the difference that you get on transvaginal. Very, very convincing, saying that this is abnormal. This is definitely lateral ventriculomegaly in the first trimester. And this is, of course, how the cyst looks in the postcranial fossa. Those are the cerebellar hemispheres that you see here. I've taken a volume and I've done a mid-sagittal section out of the volume here, and you will clearly agree with me that this is the large postcranial fossa cyst, and this is the tentorial line, which is really lifted off. So when there is a cyst like this with a lifted off tentorium, I'm going to be worried for Dandy Walker malformation. And we've got another surprising finding, and that surprising finding is the nature of the brainstem. The brainstem should be more or less straight now, whereas here it's got one kink there, another kink there, and this is persistence of the primitive cervical flexure, primitive pontine flexure. They should have gone away by now, but they are persisting, and they give rise to the classical Z-shaped brain stem, Z configuration of the brain stem. So when you see a Z configuration of the brain stem, you're really worried about a Walker-Warburg syndrome or a Hardy syndrome. Hardy is hydrocephalus, agiria, retinal detachment, encephalocele syndrome. Here there is no encephalocele, but instead there's a Dandy-Walker malformation. And in this syndrome, there is agiria. But remember, agiria can be diagnosed only after 24, 25, 26 weeks. That's the time when you're confident about agiria or Iniencephaly. Now you cannot. There's no way you can think of diagnosing a Iniencephaly. But once I know that this could be a part of Hardy syndrome, I will go and look at the orbits, because I expect to see some orbital findings. When I do the orbits here, surprisingly, you see, or expectedly, you see that the lenticular echos are very thick and the hyaloid artery is extremely thick. So this could be a cataract with a very thick abnormal hyaloid artery, or it could even be a very early retinal detachment. On the whole, there are ocular findings, and that actually clinches the diagnosis, and you have picked up a Walker-Warburg syndrome as early as 13 plus weeks. That is the importance of switching probes. That is the importance of going multiplanar. Very important. If I had not done the mid-sagittal plane, meaning if I had said, okay, these are the findings, let me report it and let go, no, I would have missed this diagnosis of Hardy syndrome, because I know I have to do all the planes, the coronal plane, the sagittal planes. To complete the neurosonogram, I took a volume and I did a mid-sagittal plane, show the classical Z-shaped, and then that prodded you on look for the ocular changes. You found it, and that is a Walker-Warburg syndrome, which you have picked up. All you need to do is to do an invasive testing and see what are the abnormal genes. You have a series of POMT1, POMT2, 3, so on and so forth, which gives rise to this condition, right? Lastly, before we wind off, I just want you to remember that you need to see what is the covering just outside of the brain we need to see. And what outside of the brain is the skull. Now here is a 12-week cranium. Nothing wrong with the choroid plexuses. They look all normal. But I just want you to look at the calvarium. the calvarium looks, it does look normal, and this is the normal calvarium. I'm missing the presence of this ossified areas. The calvarial ossification is not forthcoming at all. So this is a membranous calvarium, and therefore you have to think of an osteogenesis imperfecta. And when I play this clip for you, you will agree at 12 weeks these limbs appear a little small. You know, the midline, the two hands are not really touching, and it looks a little small. But I was wanting some more time. So I said, you go back, there is a problem, we will try and sort it out. And they came back at 16 weeks. At 16 weeks, things are much, much more clearer. You don't see the ossification at all. The near half of the skull, the intracranium looks extremely clear, which is not good. That means the calvarial bones are not ossified. When I do a coronal of the chest, you find a bell-shaped thorax out there, and now you will definitely agree saying that this is micromelia. The long bones are all short. So that is a classical osteogenesis imperfecta type 2. And when did you suspect it? You suspected it at 12 weeks. So therefore, the calvarium can hold sometimes information, and it is for us to kind of pick up those findings. Oh my God, this doesn't look normal. So let me look at the calvarial bones properly. Let me look at the long bones properly, and then you will call them not for an 18-week scan, you'll call them a little earlier, and you stumble upon the other findings, and you have picked up an osteogenesis type 2 imperfecta, right? So we need to understand what are the CNS anomalies that cannot be detected in the 11 to 14-week scan, right? Complete agenesis of corpus callosum, microcephaly, lissencephaly, arachnoid cyst, vein of Galen aneurysm, hydrocephalus in its full form, infective sequelae, cerebellar hyperplasia, so on and so forth. You have to give time for this baby or this fetus to grow. Only then these abnormal findings manifest at well in the mid-trimester anomaly scan or even a little later. So conclusion is that in the first trimester, you can diagnose some lesions with confidence. And those are anencephaly, iniencephaly, an encephalocele, or holoprosencephaly. You know you can spot them and diagnose them, no two ways about it. Whereas in other situations, you need to wait. And what are these situations? The screening situations. For example, the IT. If you have an IT which is obliterated and you're not very, very confident of picking up an abnormality in the spine, in spite of doing a transvaginal, you wait, you call them back at 16 weeks and look at the spine again. More often than not, you will find the spinal lesion, or you'll find a small occipital meningocele or an encephalocele. Again, IT obliteration, an increased IT could be a marker for Dandy Walker malformation, or it might not be a Dandy Walker malformation. And I just skip this case. I'll just take you through this case because it is directly relevant to the statement which we read just now. And this is, of course, a 19-weeker posterior fossa cyst. I showed you one case of a posterior fossa cyst where the outcome was dreadful. It was a Walker-Warburg syndrome. But let's look at the other side, the other side of the coin. That is the posterior fossa cyst. That is a cyst on the midsagittal section. Then I said, no, that's the little thing, that's the vermis, that it's not as elevated. I said, let us wait, nothing, you won't lose anything. And this lady was indeed in the medical profession. She waited, she came back almost at 19 weeks, and at 19 weeks, the cyst was there in the caudal section of the PCF, not in the cranial section. So caudal section opened fourth ventricle, cranially the vermis was seen, and I said, this needs a mid-sagittal section, just like we did the mid-sagittal section here. And in the mid-sagittal section, this is the clip I want to play. That's the corpus callosum at 19 weeks, and this is the vermis, a fairly decent vermis. Maybe it's a little rotated over here because the fourth ventricle looks a little prominent. Looking at the vermis, I was really, assured that I have not taken this lady on the wrong direction. The vermis looks normal to me in terms of size and shape. So I said, you go away, come back after 3 weeks. She comes back 22 weeks. And at 22 weeks, you find a very good normal vermis, and a vermis that is seen here. And 27 weeks, you see that the cerebellum looks almost normal, except that one spot is a little bit of an open fourth ventricle. But see how the change has occurred. From a postcranial fossa cyst, it became a Blake pouch cyst, and then at 34 weeks, there's hardly anything in the postcranial fossa which will get your antennae up. So a cyst in the postcranial fossa in the first trimester can go both ways. On one hand, it can have a happy ending. On the other hand, it can have a dreadful ending, as we saw in this case, Walker-Warburg syndrome. So therefore, it is screening. You have to wait and watch and see whether it takes the Dandy-Walker malformation route or the Vermian hyperplasia route, as we saw in the Joubert syndrome, or whether it peters off into a Blake's pouch cyst, and ultimately the Vermian rotation is gone and it becomes normal. So remember, use transvaginal ultrasound, because your pictures become that much better, and when your pictures are better, your diagnosis is more stronger, and the conviction with which you make your report becomes more. And if there's any doubt, don't press panic buttons. Please call them back. If not at 18 weeks, 20 weeks, call them back at 16 weeks, and then you can follow it up. At least see whether it is something progressive in terms of the findings evolving, or whether it is whatever you saw is actually regressing. So be very liberal with your early scans, and then that would be the proper way of sorting out these problems in the first trimester. So thank you very much for a very patient listening. I hope this lecture drives home some very important lesions that we can diagnose in the first trimester, or suspect and follow up. Both ways, we must have an open mind. Thank you very much indeed. Thank you.
Thank you very much, sir, for this very informative talk on first trimester CNS and showing us various anomalies which can be picked up in first trimester scan. And it's a pleasure for us to have you on this webinar today. Vote of thanks to our viewers for joining us today. Thank you, good night, and stay safe.
Thank you.